Wonderful presentations, both of you. There are loads of questions, but before we go to the questions, may I request our experts for the evening, Dr. Derek, Dr. Jitangi, and Professor Maya, to pitch in with their comments. I think we'll go alphabetically. We'll start with you, Dr. Derek.
That's very kind of you. I think Dr. Hopkins and Dr. Murphy have done a fantastic presentation and really covered the literature very well. So, and I want to congratulate the association for a very nice session you put together, actually. So I'm not going to add anything else. I think it's excellent.
Dr. Jitangi, anything from your side?
Yeah, hi. Thank you so much. And thank you to AOCN for having me. And also, I'd like to echo what Derek said. It was very comprehensive. But just to sort of, it's really interesting to exchange your experience with the experience that we have here, because as you quite rightly said, that there is such a big difference in the incidence of pediatric onset MS in this region. I would actually just like to sort of, pose two questions. First to Dr. Amma, who also did a fantastic job. So whether you could actually is there an explanation as to why there is this big difference across the equator? Is it just the vitamin D deficiency status in the countries away from the equator, or I was intrigued by the gut microbiome. Do you think that there is any other explanation that could explain why it's such a rare disease? Pediatric MS is anyway rare, but why is it such a rare entity in our parts of the world?
So just to clarify, the question is, why is it rare, more rare in the Middle East and Southeast? Is that the question?
Yeah, that's right. Yeah.
Yeah, I mean, from the literature that I was reviewing, there are multiple factors that take part in the pathogenesis of MS, and it's more about the interactions between these factors together that increase the predilection of development of MS in a patient. So I think even though we know so much so far about the pathogenesis, there's so much that needs to be uncovered. I think that there are now more studies talking about the gut microbiome and how the interaction between the gut microbiome and the going into the CNS compartment increases the risk. But there is also, I think, an interest in looking at genome-wide association studies to see if the patients in different parts of the world have different risks. And I don't think it's I don't think it's just the vitamin D. I think it's more than, it's multiple things taking part in the pathogenesis in different patients. What happened here?
Thank you. Yeah.
We can hear you okay. I think vitamin D is probably part of the story. But I don't know that there's data that it's the whole story for sure.
Thank you. Yeah.
Thank you for that. Dr. Maya, anything from your side?
Thank you, speakers, for that wonderful presentation. Yeah, I would like to listen to the case presentations and more time for all the questions and answers. I think there are a lot of interesting questions that have come up in the chat box.
Yeah, I'll start shooting the question. I'll leave it open-ended between Dr. Sara and Dr. Amar. You can take it on as you feel like. One of the questions is regarding the Epstein-Barr virus testing in MS. So what kind of test do you go for? Do you go for a quantitative PCR, checking the viral load, or is it just a positive or a negative test? And if it's a quantitative PCR based, what exactly is the cutoff that you say, okay, yeah, this is possibly we can link to MS?
Yeah, so we don't do a PCR test. We do an antibody test. It often is an ELISA, but an immunoassay for sure, and look at antibodies indicative of past infection. If a PCR was negative, it doesn't necessarily, it doesn't really define the risk. So it would definitely be looking for an antibody test that was indicative of past infection, past or present infection, at least.
Okay. And what's your approach to a radiologically isolated MS?
Dr. Amar, you want to take that?
Yeah, sure. So it's mainly going to be a discussion between us and the family. And it depends on we start by taking a story and seeing if and we can identify any clinical or historical information if there was any relapse. But if it's truly radiologically isolated, we can offer doing a lumbar puncture to stratify the risk of developing MS. But regardless, we cannot give a diagnosis of MS even if you have evidence of oligoclonal bands. So it's going to be a discussion between the family and us, but it wouldn't justify starting disease-modifying therapies at this point.
So what I would just add to that the first thing we do, so if we see a patient with radiologically isolated syndrome who doesn't have evidence of a clinic, who doesn't have historical evidence of a clinic attack, then we also would look for other evidence that there's something related to a possible MS diagnosis. So we'd have them see neuroophthalmology for OCTs. If they haven't had a spinal cord scan, we would do that. And then we would usually also do neuropsychological testing to be sure that there wasn't some little evidence there. And then if, of course, we can find evidence, some kind of evidence of clinical disease, then we would for sure go on and do the lumbar puncture and suggest treatment. But at this time, we are not treating radiologically isolated syndrome without clinical disease. That may change, but right now we're not.
Okay. The next question is, what's your approach to a neurobeshet's patient?
So say we don't
cover
have
it,
Behçet
but,
patients. I think all of one who did well on infliximab ultimately, but we honestly don't have much. And actually, I would be curious to see how much more of that you see in your region than we do. But very rare here.
Very rare over here also. Yep. And what's your approach for a B27 related optic neuritis, HLA B27 related optic neuritis?
Is that the one that's associated with ankylosing spondylitis, or?
No, so there's a question by one of our attendees. They have patients who have optic neuritis and who are HLA B27 positive. So does it change anything, or the management more or less stays on the similar lines? Or does it change the long-term management? Any experience related to that?
Do you, Dr. Hopkins, have any experience with that?
So we honestly don't typically check HLA subtypes in our relapsing optic neuritis patients. I'm not sure that it would change our management all that significantly, but I don't know that I can answer that exact question. I would say that I think that the vast majority of our cryon patients are treated with rituximab, sometimes monthly IVIG in some cases if their clinical presentation is reminiscent of MOGAD, but I would say those are the most likely things that we would use.
And how frequently do you encounter cranial nerve abnormalities in patients with demyelination right at the presentation? So they're presenting with, apart from optic neuritis, of course, cranial nerve abnormalities.
So it's not a very typical presentation, but we can see patients who have a lesion that's affecting the pons, affecting the nerve fascicle, and presenting with a Bell's palsy, and then manifesting later on with more brainstem symptoms. And there are the occasional patients who present with trigeminal neuralgia because of that irritation around the trigeminal exit trigeminal nerve exit, and that presents with cranial. It is technically a cranial neuropathy, but these are the ones that I can think of. And when it comes to MOGAD, they do have some leptomeningeal disease, and they can present with some cranial neuropathies, but the predominant picture would be more of a central nervous system process.
Yeah.
Okay, next is related to therapeutics. I'll just club some of those questions together. So what is the typical Ritux regime that you follow in terms of the dosing? And when we have to repeat the next dose, is it a protocol that you test for CD19 before you give the next dose? And third part of Ritux is how frequently, or what is the duration for which you give, 2 years or
Yeah, so I think it's dependent a little bit on the neurologist and a little bit on the disorder and a little bit on the patient. So we tend to really like rituximab because we know our patients are compliant. So I think that's a big reason why it tends to be one of our favorites. Typically, when we really started using it, we really went with the arthritis dosing because that's what our rheumatologists use the most. So we tend to use the 750 mg per meter squared, 2 doses 2 weeks apart, repeated in 6 months. But I do think it's important to underscore, as you mentioned, that you do need to check CD19 counts because there are some patients who will reconstitute much faster and need earlier dosing. And then there are also a handful of patients that don't reconstitute by 6 months, and you can stretch that out a little bit. What we've started doing more recently is if we have a patient who's not who's on that dosing regime and is not reconstituting their B cells till 6 months, sometimes we will actually go to just 1 dose every 6 months to minimize the amount that they see. Of course, keeping a really close eye on the CD19 count during that time. I will also say the other subset of patients I take care of is pediatric opsoclonus myoclonus patients. And for whatever reason, sometimes those really young kids reconstitute their B cells really quick, sometimes just 3 to 4 months. So important to keep that in mind if you've got somebody in an anti-CD19 CD20 therapy, that if something's not going as planned, to really keep a close eye on those cells. The one other thing I would just as a reminder is that sometimes in our patients on Ritux, we do see hypogammaglobulinemia. So sometimes when you check those CD19 counts, throw an IgG in there as well.
Okay, there's a question. What is the seroconversion time for MOGAD? I'll modify it. So how frequently do you test for MOGAD during the follow-ups? Do you test at all? And if yes, if you have to test it once, what is that one good cutoff time that, okay, this is a good time to test for it?
Dr. you want to take that one?
Yeah, sure. So we know from the studies that the titers are highest around the relapses and typically with the initial relapse. So the best time to test it would be around that initial relapse. We don't typically keep following the MOGAD titers because we've seen from many patients that they can remain positive, and even after some time, patients can continue to have positive titers on, although they get lower. Sometimes we do test at the 2-year mark when we want to decide to wean them off the immunotherapies, just to stratify the risk of relapses. So if it's negative, it might help us to say that the risk of relapse is lower. If it's positive, we might counsel the family that they have to expect a relapse, even though they're far out from the disease onset. But there are patients who actually relapsed many years after the initial attack with a negative MOGAD titer. So it's not 100%, but it can help us with in that sense.
Fair enough. Another thing related to the follow-up only, how frequently do you perform the radiological assessment in the follow-up? Is it like some centers do it 3 monthly for the first year, and thereafter they keep on spacing it apart, and or especially in conditions which have a propensity for relapsing. So let's say in those which have a propensity for relapsing versus those which are unlikely to relapse. So do you have a protocol for radiological follow-up for these patients?
Yeah, so it depends on the disease. With MS, we do know that they can have silent T2 flare lesions. So we typically get a baseline image 3 to 6 months after starting the disease-modifying therapy, and that would be your baseline, and you would expect like you would consider that your baseline, and then it would be either 6 months or annually for patients who are stable. That's for MS. For MOG and aquaporin 4, because we know that typically their new lesions would be symptomatic, we don't tend to follow them with sequential imaging unless we want to get a new baseline of normal for patients who have ADEM or MUGAD, but we don't typically follow them with MRIs.
The one thing that I would add is sometimes if you have a patient with MOGAD who say presents with a large spinal cord lesion and you just want to get follow-up imaging to document that, yes, there's improvement. Sometimes that's helpful for everybody's sanity, even when they're improving clinically. Sometimes you will see that there are, for instance, new clinically silent cerebral lesions that perhaps developed at the time that they were sick, sometime early in the course of treatment. So they're new since the initial exam, but probably associated with that first event. And that kind of clinically silent lesion in MOGAD does not really change management at all.
Perfect. Thanks a lot. I think I've tried to cover most of the questions which were there in the chat box. Most of the questions were answered during your talk itself, and the rest we have tried to cover over here. There are still more questions from any of the participants. They put it in the chat box, and I'll request you to kindly go through it and answer it live over there while we move over to the case presentation. So we have 2 cases which will be presented today. I'll request both of you to give in your inputs wherever you feel necessary. So the first case is from Kolkata, NRS Medical College, presented by Dr. Bonnie Sain, and the faculty who will be moderating that will be Dr. Jishodra. Dr. Bonnie, can you please start sharing your screen and we can take it on from there?
Yes, sir.
To Vishal, 6+2.
Yes.
So, am I audible, ma'am?
Yeah, you have about 5 to 6 minutes to present.
Okay. Is my screen visible?
Perfectly visible. Please go ahead.
So, good evening, all my respected teachers. Myself, Dr. Bonnie Shen, doing DM Neurology Residency at NRS Medical College. And today I am going to discuss a atypical case of pediatric demyelinating disorder. So, this is a 12-year-old boy from South Chobbish Pargona who presented to us with for last 3 weeks of weakness, which was quite acute onset progressive spastic quadriplegia, more in the lower limb than upper limb, distal more than proximal, with sensory loss in the form of numbness below the neck and urinary symptoms in the form of urgency with incontinence and increased frequency. Though there was no history of any visual symptoms, cranial nerve, encephalopathy, or any systemic features, or any history of prior vaccination. 3 years back, patient had a similar episode of spastic quadriplegia with respiratory distress, but no documents were available for that episode. Patient recovered by motor weakness over next 1 month with complete recovery, but some urinary problem persisted. And 6 months back, the patient had repeated episodes of vomiting lasting for 7 days associated with hiccups which resolved spontaneously without any motor weakness, sensory autonomic symptoms. So we examined the patient and general survey revealed no abnormality. Neurological examination revealed RAPD at right eye with spasticity in all 4 limbs with bisque, jar, ankle, chronus, bilateral extensor, plantar, and symmetrical sensory loss below the neck. And this is the fundoscopy finding, which shows mild temporal pallor. So if we see the course of the illness, there are 2 episodes of motor weakness with some persistent sensory and urinary symptoms, and 1 episode of hiccups with vomiting, which was 6 months ago. So after examination and history, the localization is the spinal cord, probably due to symmetrical hollow cord involvement and without any apparent compressive feature. Probably it is a non-compressive myelopathy, longitudinally extensive transverse myelitis, and considering the course, relapsing remitting course, probably it is a demyelinating etiology. So we started investigating the patient. Routine investigation was normal with normal serological report with all infective profile was negative. CSF study was normal with a mild rise in protein. Vasculatic profile was negative, and CSF, OCB, and IgG index was negative with negative anti-NMO and MOG antibody. And MRI of the spine revealed hyperintensity from C2 to C6 level, which is long segment more than 3 segment myelitis with mild post-contrast enhancement. This is the axial cut showing the same. So we further performed the VEP study, which shows increased P100 latency. And orbit star image shows bilateral hyperintensity in anterior part of the optic nerve, bilateral with signal intensity. But MRI brain shows a striking feature of a cavitary lesion in left parieto-occipital region with another lesion in the right parieto-occipital region with mild perilesional edema without any significant midline shift. But on contrast study, it takes the contrast in an open ring type of enhancement. There was no diffusion restriction as well. So this is the sagittal section. So now what is it? We further perform MRI spectroscopy study which shows reduced NAA with increased choline creatine ratio, and report gives suggestive of neoplastic lesion which is not convincing at all. So we further did the FDG PET scan which is available in our hospital, which shows hypometabolism rather hypermetabolism without any evidence of primary malignant foci. But we could not perform the more confirmatory study like MR perfusion study or stereotactic biopsy due to some logistic issue and denial from patient party. So now what is it and how to differentiate? Is it a tumor, abscess or tumor factor demyelination? Simultaneous enhancing and non-enhancing lesion in the T1 image, is it a black hole indicating dissemination in time? And how common such type of tumor factor demyelination is present in pediatric population? So we are in a diagnostic dilemma. Our probable diagnostic after ruling out all autoimmune, infective and neoplastic causes is a primary acquired demyelinating disorder, probably a seronegative NMOSD. Then comes the pediatric multiple sclerosis as considering the tumefactive lesion, and Marburg variant is less likely because it is more fatal, and lastly the MOGAD. So there, these are the some positive findings. The MRI spine is more suggestive of NMOSD, whereas the tumefactive lesion more suggestive of pediatric MS or MOGAD, and optic nerve lesion is more suggestive of MOGAD. So we are in therapeutic dilemma. So considering the tumefactive demyelination approach, we started the patient on IV methylprednisolone at 30 mg per kg per dose once daily for 5 consecutive days. Then we put the patient on oral steroid at 1 mg per kg per dose for 6 weeks tapering dose, and treatment response is noted by EDSS score and repeating the MRI after 6 weeks. And it showed non-contrast enhancement after 6 weeks of post-steroid treatment, and also the size of the cavitary lesion reduced from the previous lesion. So what second line immunosuppression to be chosen to prevent the future relapse as the conditions are overlapping. So we reviewed the literature and we find that rituximab is effective in case of even aquaporin negative NMO spectrum disorder compared to azathioprine and mycophenolate mofetil, as well as rituximab is also effective for RRMS as RCT phase 2 trials are going on this. So we started after pre-treatment workup like viral hepatitis, TB workup and CD19 assay. We started rituximab on a dose of 750 mg per meter square, 2 doses at 2 weeks interval. Then we planned for it for every 6 months. And the EDSA score significantly improved from 7 to 1. And the patient who came to us started walking alone without any support during discharge. So we planned
Sorry
to
to
follow the patient
hello.
after by repeating MRI at 3 months, by repeating antibody testing, and by doing EDSS score on each visit. So thank you.
Thank you, Dr. Boni. And Dr. Jashodhara, comments from you?
Thank you, sir and ma'am. So the things, our questions to the experts and teachers will be that we saw the clinical features matched with NMOSD. There were repeated vomitings, there were long segment myelitis, and so many episodes were there. But however, the radiological feature, there was one tumefactive demyelination with open ring enhancement, and there was also the anterior to third part of the optic nerves were involved, which matched with MOG and the tumefactive demyelination matched with MS. Along with that, there was a black hole also found in T1. So that these two things are not matching. And also after rituximab, the patient responded very well. Now coming to our follow-up. And also there was a study which got published in European Journal of Pediatric Neurology this February 2024, which shows that rituximab is as effective in pediatric MS. So what happened and what is the actual disease? Now we are in dilemma. It responded to rituximab, that is fine, but all the antibodies being negative, and the clinical and radiologic these findings are just overlapping with each other. So I'd like to get comments from the experts regarding this etiology.
Dr. Amar, do you want to go, or would you like me to go?
Yeah,
Either way.
I can start. And then, so yeah, as you guys pointed out, there are multiple features that are supporting NMOSD. The longitudinal extensive myelitis, the relapse within a short period of time, and the area postrema presentation with the vomiting. I would want to ask what technique was done for the testing of the aquaporin 4. That would be
Cell-based assay. Cell-based assay technique.
cell-based assay. Yeah. One thing, some patients with NMOSD actually respond well to rituximab, so I wouldn't factor that in the like favoring MS over NMOSD, because we do see good response with rituximab in NMOSD. Yeah, it is true that patients with NMOSD optic neuritis have more of a retrobulbar and chiasma, but they can also have bilateral long segment anterior involvement of the optic nerve, so I wouldn't put so much weight on that. The last thing is the black hole. NMOSD itself, it is destructive, so I wouldn't be surprised if it was a very aggressive presentation that now over time we do see a black hole or encephalomalacia in this case. I would be interested to question if there is an overlap syndrome. We do know that NMOSD can have overlapping autoimmune processes outside the PNS, like myasthenia gravis, vitiligo, XYZ, but then there is also an overlap with things like NMDA or glial fibrillary acidic protein or other encephalitides. So I would be curious to see if those were considered. These are my thoughts.
Yeah, no, I think that's really comprehensive. I think the thing that stands out the most to me, probably because my interest is in myelopathies, is that spinal cord lesion is not typical of anything that we would see in multiple sclerosis. So the reverse can be true. You can have a shorter segment lesion and have it turn out to be neuromyelitis optica, but that kind of longitudinally extensive lesion, I really don't think is associated with multiple sclerosis, even tumefactive multiple sclerosis. So that brain lesion could be tumefactive MS, but I don't think MS adequately explains the rest of the clinical picture. You've got classic area postrema syndrome, which even when it's mild is still most commonly neuromyelitis optica, and that longitudinally extensive lesion and bilateral optic neuritis. Even though luckily it was mild, I think that's still the diagnosis that fits best. At the same time, it's easy to get into, I have to put this patient into this category. And so often it's just important to continue to think outside the box and just communicate to the families, that we see some things that maybe go with one thing better than another, but all these things are treated with this medicine, and sometimes that's okay. I agree with Dr. Amar that it may be worth looking for additional autoantibodies. I'm not sure what antibody panels are easily available to you. We typically use the Mayo Clinic lab. There's an autoimmune myelopathy panel. There's a pediatric autoimmune encephalopathy panel. So something along those lines may be helpful as well if there's some other antibody that we're missing. So for instance, I think it's CRAMP5 that can also cause optic neuritis, and there are some other autoantibodies that can cause longitudinally extensive myelitis. So maybe worth a look. And also to keep in mind that sometimes your aquaporin 4 is negative and may come up positive sometime later. So I would check it again in 6 months or so.
Thank you, ma'am.
Thanks
Thank
a
you,
lot.
Dr. Derek, Dr. Jitangi, Dr. Maya, Dr. Udani.
I have a question. How I may have missed this in your presentation, but how common is it to get a negative antibody titer in a typical NMOSD disorder, say in aquaporinopathy?
Madam, we may get negative panel, we often get, but the criteria here, it was like the radiological criteria was not matching. So negative antibody, we often get like these things are negative. Because we have different kind of assessments, and sometimes we cannot send a repeat one. As suggested right now, we cannot, due to financial constraints, we cannot send a repeat one.
Understood. Then I think that really this patient meets sufficient clinical criteria for an inflammatory demyelinating syndrome. They've responded to rituximab, and I don't know. I don't know that I would do anything different at this point. It sounds like you're managing the patient well. He's doing well. So I think that's the key.
Thank you.
Udani, sir? Yes.
I just want to ask a question. I mean, what was the flare or that large cystic lesion in the cerebral cortex, which appeared to be something cystic? Was that flare negative as well?
No, sir. Yeah, it was hyperintense in T2 flare image with some perilesional edema, but there was open ring type of enhancement on post contrast study, and the open part of the ring was towards the gray matter. So this kind of MRI picture we got in this case.
I see. But this kind of extremely low T1 kind of hypointensity is very unusual in the acute stage.
Yes,
I
sir.
mean,
This is
in fact,
unusual.
demyelination, I agree with you, has open ring enhancement that's usually in the wall of the, see, this was quite distant from that area.
Yes, sir.
So I was not sure. I mean, I was wondering whether that was in fact something else rather than
Yes, sir. That's why we performed also PET scan and MR spectroscopy.
And your transverse myelitis, etc., may have been, these things look like maybe there was something there from before. I don't know. So I was just a little, I've never seen a black hole that big. Have you, Dr. Hopkins?
So we've got a couple of very odd, we have a handful of very unusual patients. So there are a couple of things that I'm not sure about this patient. So one is that there is a remote history of neurologic symptoms. So and from my understanding, as far as I know, this is the only scan we've had, right? This was the first time he was scanned in spite of the fact he'd had symptoms in the past. So I'm not sure if all of the things that we see on MRI are new versus if some of them are old. Is some of this marked T1 hypointensity from an older destructive process? I don't really know. I think that's a good point. I think that if it's available, a follow-up scan, perhaps in the 6 months range, would not be a bad idea. I think it's a great point that this lesion is not necessarily one that I would just say, oh, he's doing okay, and just leave it. I think it may be informative to get a follow-up scan. But I think in terms of diagnostic odyssey, I'm not sure I can think of much else that you haven't done that would help clarify the picture in a patient that's doing well with what you're doing.
Thank you, ma'am.
Dr. Derek, Dr. Jitangi.
If I may just ask a question, I mean, we did consider a possibility of an overlap syndrome, and we consider possibility of tumor factory MS. Is the entity of Schilder's disease a non-existent entity now in the nomenclature, or would you consider that possibility considering an overlap syndrome?
So, we did not come across such a case, such type of condition.
Maybe we can ask Professor Hopkins, what would be your thoughts on that?
Yeah, so I would say I've been here at CHOP 10 years, and I've been doing this for 12 or 13, and I've not seen what I was convinced was a true pediatric onset case of Schilder's disease. I've one that meets criteria for Baileau's concentric sclerosis, but in a tumor-affected MS patient. But that's a good question, and I haven't actually thought of it that way. But I don't know that I've seen anyone that I thought had that diagnosis convincingly.
Derek, anything from your side?
No, I think you've kind of covered it, everything. I mean, I would agree it would be useful to get an interval scan to see if that lesion kind of shrinks and gets better. It'd be a bit suspicious if it stays same or gets bigger. You mentioned it's not possible to repeat the antibody.
Yes, sir, we will do that. We will do that. We'll repeat the image because that is not a financial burden, but the antibody is a financial burden to the patients over here.
Okay, right. Yeah, I mean, of course, if money was no object, obviously, then if it was very key, then sending to a reference lab would be helpful, I guess, to crystallize it. But understand it's not possible.
Thank you.
One thing I would just add, and I'm not saying that it's what this patient has, it was higher on my differential looking at the initial scan and not knowing before I knew how he did clinically. But we do have kids that also have neuroinflammatory disorder overlap with mitochondrial disease. That can sometimes present with large lesions, like longitudinally extensive transverse myelitis. There's, of course, the overlap with Leber's hereditary optic neuropathy with multiple sclerosis. It's called Harding syndrome. So there are some mitochondrial disorder kind of overlaps as well. So, and I would just keep that in mind if he didn't do clinically well, although it sounds like you have him on the right track now.
Thank you, everyone. We will move on to the last part of the session, which is the second case for the evening. This is from CMC Vellore. Dr. Kirutiga will be presenting, and Dr. Sangeeta will be moderating that session. Over to the CMC team. You can go to the slideshow and start presenting.
My slides visible, sir?
Visible. Please go ahead.
Good evening, everyone. I thank AOC and my professors for this opportunity. I am presenting an unusual case of Mogat. Presenting a 4.5-year-old girl was brought with complaints of fever since 28th of April 2020, followed by seizures and altered sensorium since 18th of May 2020. Her mother's antenatal history, natal and unit period were uneventful. She was typically developing child. On 28th of April, she developed low-grade fever, which was managed symptomatically. From day 3 of illness, she developed high-grade fever, not associated with any signs of any symptoms sensitive of of infection. Evaluation revealed neutrophilic leukocytosis. She was managed elsewhere with IV medications. On day 20 of illness, she developed clumsiness of gait and fever provoked to right focal motor status epilepticus, followed by altered sensorium, during which time neuroimaging revealed hyperintensity in bilateral thalami, right more than left, caudate nuclei, and diffusion restriction in right perioccipital region. And she was managed with antibiotic medication. CSF analysis revealed lymphocytic pleocytosis with elevated proteins and elevated acute phase reactants and leukemia reaction in complete blood count. And infective echo revealed Wilfelix being positive, and all other were within normal limits. She was managed as focal cerebritis with IV antibiotics, anti-seizure medications, and IV followed by oral steroids. Though there was improvement in next 2 to 3 days, on day 26 of illness, she developed new onset symptoms characterized by numbness of hands while reaching for objects and emotional lability. And following a neuroimaging, she was referred to CMC. The second neuroimaging revealed hyperintensity in bilateral caudate, caudate with perioccipital and frontal white matter hyperintensities and a diffusion restriction of the same. There was no history sensitive of the neuraxis involvement. General examination revealed irritability, normal vitals, and normal anthropometric measurements, and bilateral palmar erythema. Neurological examination revealed irritability, generalized wasting, hypotonia, extensa plantans, and posterior cerebral assays. So 4.5-year-old girl with normal development with a history of fever for 1 month, altered sensorium and seizures. The examination revealing irritability, central hypotonia, cerebral assays. The size of neuraxis involvement of cerebral cortex, cerebellum, and its connection. The possibilities considered were infection, primary immunodeficiency, systemic vasculitis with CNS involvement, infectious CNS demyelination, neurosarcoidosis, and lymphoreticular malignancy. Neuroimaging, this is the first neuroimaging done in CMC, which revealed bilateral caudate and anteriputamen hyperintensity with asymmetrical subcortical white matter hyperintensities, and also hyperintensity in the cervical cord region with no significant contrast enhancement. And EEG revealed focal slow wave disturbances. CSF analysis revealed mild hypoglycemia with the infective and autoimmune workup being negative. And bone marrow examination slides done outside were reviewed, which revealed myeloid hyperplasia. Other examination of the normal limits. Blood investigation revealed elevated acute phase reactants and spotted fever, IgM, ELISA were positive. Other infective and vascularity workup was negative. Edema-history scan revealed antibody for MOG being positive, and HLH and ALS workup was negative. So the final diagnosis of a myelin oligodendrocyte glycoprotein-associated CNS demyelination, MOGAD, was considered. As it was associated with the spotted fever rickettsiosis, she was treated with doxycycline and IVIG, which was given over 5 days. Oral steroids, which was initiated elsewhere, were tapered and stopped. At discharge, there was improvement in her sensorium and ataxia. 2 weeks later, she developed new onset symptoms characterized by visual disturbances and worsening of her tremulousness. An examination revealed no features of optic nerve involvement and generalized wasting cerebellar signs. Repeat neuroimaging revealed bilateral symmetrical ovoid hyperintensities in the perioccipital, temporal, and brainstem region in the T2 and T2 flare axial sections, and peripheral diffusion restriction and peripheral ring enhancement of the same lesions. Repeat investigations revealed again MOG antibody being positive. And so she was managed with pulse intravenous methylprednisolone for 5 days, followed by rituximab weekly for 4 doses. Her discharge visual acuity improved significantly. During a follow-up, she had complete resolution of symptoms within 1 month. Her other issues were leukocytosis, which normalized over a period of few months. And 8 months after the onset of illness, she had inadequate B cell suppression with the MOG antibody being weakly positive. So repeat MRI was done, which revealed T2 flare hyperintensities in the perioccipital region, which was significantly reduced compared to the old imaging. And she received 2 doses of rituximab. And her repeat MOG was negative in November 2021. And after a few months, she developed rituximab-induced hypogammaglobulinemia, for which she is on monthly IVIG infusions. Currently, last month, her IgG level was 771. Currently, she is in class 3 with good scholastic performance, and there are no visual concerns. This is a follow-up last imaging done 2 years back, which showed bilateral flare hyperintensities in the perioccipital region with no brainstem or cord involvement. A few words on MOGAD. MOGAD is a CNS inflammatory demyelinating disease with the incidence of 3 per million. It usually follows a viral prodrome and can be monophasic or relapsing. MOG is a minor MOG forms a minor component of the CNS myelin, which is expressed on the outer sheath. Following a trigger, MOG-specific B cell is differentiated with the help of T follicular helper cell into MOG-specific plasma cell, which produces antibodies, which crosses the blood-brain barrier and attacks the MOG protein present on the myelin sheath, thereby causing demyelination.
Ma'am, 1 minute is remaining.
Fever and MOGAD. In MOGAD, is hypothesized that interleukin-6 and granulocyte colony.
I think we can stop here. We have had a long session on MOG. We can have discussion on your case instead in the interim period. Dr. Sangeeta, we'll start with your inputs.
Yeah.
Thanks, Kritika, for the nice presentation. So the learning points from our patients are like the clinical and radiological spectrum of MOGAD is evolving. The common presentation that we often see in MOGAD are optic neuritis, myelitis, and ADEM like presentations. But the other presentations that we need to keep in mind are brainstem syndromes, otherwise MOGAD presenting as a prolonged fever with established demyelination. Some children with MOGAD can present with like a fever of unknown origin or unexplained origin, and claims like presentation, which is like a clinical radiological entity. So in our patient, she presented with like a prolonged fever, and she had initially had an encephalitic presentation with seizures which was managed outside, and the peripheral blood complete blood count revealed persistent leukocytosis with leukemia reaction, and also she had elevated acute phase reactants, which includes CRP and ESR. So later she presented with a posterior vision loss. What often we see is the anterior vision loss, but in this child she presented with a posterior vision loss, and her optic nerve and fundus examination was normal. There was no RAPD, but she had inconsistent visual fixation and following. So this was one of another unusual presentation. The first MRI was showing atypical, asymmetric involvement of the thalamus, and also she had a right parietal cortex diffusion restriction and hyperintensity. Later, when she presented with the posterior vision loss, she had almost multiple ovoid lesions involving the parieto-occipital white matter with an enhancement, which is again a very atypical picture which we have seen in our cohort of patients with MOGAD. So fever is again well documented finding in children with MOGAD and has been described in more than 1/3 of cases. And nearly about 70% of children can have fever for more than 1 week. And the reasons could be because of the inflammatory cascade leading on to the release of interleukin 6, and also the granulocyte colony stimulating factor, which is also elevated in children with MOGAD, which can explain the elevated WBC count in the peripheral smear, and also can explain the elevated acute phase reactants. Udani sir has already published a series of patients with similar presentation. I would like to hear sir's comments on this.
Thanks, Sangeeta. It's a very interesting case. And I think we had published a small series of about 12 patients with either prolonged fever, like just say a FUO kind of thing, which was treated as such, and a few patients came with aseptic meningitis, which were described in several reports of MOGAD long before any demyelination occurred. And the third presentation was even more strange, that after established acute demyelination syndrome, the fever came up. So we had one patient who had a fever going on for almost a couple of months after, and we were really confused about why it's not going away. So I think this fever, I think you've basically given all the reasons, and I think very likely, but I don't know whether it's as commonly seen in the West, in the Western world, as it is seen over here, because over here, I think Vishal is right now leading a study on MOGAD, which has been, I think, what percentage you had fever? I mean, if I remember right, about 40%?
I think about 15 to 20%. So 1 in 5 had long.
1 in 5.
Yeah.
Prolonged fever, yes.
Prolonged
So
fever.
it looks like maybe we have some different types of reaction, host inflammatory response to the MOG antibody. I mean, I don't know. What do you think, Dr. Amar and Dr. Hopkins?
So I guess I would say that it's actually not that uncommon here for us to see fever in our MOGAD patients. So we definitely do see fever, and as well as peripheral inflammatory marker elevation to some extent in our MOGAD patients. I don't know that I have a specific number. We looked at that several years ago. I think a roughly comparable number, probably about 20% with fevers. But I'm not 100% sure of that number, but for sure we see it. And then,
sorry, what was interesting in our patients was the demyelination came several weeks later. So in the beginning, you might miss this diagnosis completely. When you do,
yeah.
I mean, we had a few patients with MRIs also done during the febrile phase because of headache and vomiting and stuff, and
Yeah.
nothing came the MRI. Then later on the demyelination appeared.
Yeah, that may be some.
Sorry, just whether I could, raise this question because the fever started off first and the demyelination followed on. And also I just noticed that in those MRIs, yes, it did look like a flame, like appearance, but, because of the very symmetrical appearance, whether it could be something like, infection triggered inflammatory response. Where, if we do a DWI, we would see like a Christmas tree appearance. I couldn't help, thinking of that possibility, could it have been itis, of course, whether the MOG positivity was a false positivity. I was just, thinking while looking at the image. So I'll just like, your responses over that.
Yeah, this patient initially had a rickettsial infection workup positive. Maybe that could be an antigenic trigger. But subsequently, when she was treated adequately, she recovered and she remained well for 2 weeks and then again presented with a posterior vision loss. And that time she didn't have fever as well. So it's less likely that it's directly related to the rickettsial infection itself. Maybe the rickettsial infection has triggered an immune response and then had developed a MOGAD. So that could be a possible explanation. Dr. Hopkins, do you want to add on any additional comments?
Actually, I thought we'd ask Dr. Amar for her opinion as well. She's seen a lot of MOGAD lately, so.
Yeah, I mean, interesting, complicated course. To me, I mean, there are several flags that would make me question a diagnosis of MOGAD, and I would expand my differential. I would like to know, I mean, what does the two, when it says MOG 2+, what does that indicate?
That's a semi-quantitative titer. They don't give a complete quantification.
Okay, so it's a titer is positive, but we don't know how high the titer is. Is that correct?
Yeah.
Okay. Yeah,
So they grade it as weak, 1+, 2+, 3+.
Yeah. Okay. So the thing is with, I mean, we do, when we compare MOG antibodies to aquaporin 4, we know that the aquaporin 4 antibodies are very robust, and when they're positive. Whereas with MOG antibodies, there is a variation. We do sometimes see low positive titers with other inflammatory processes or infections. So you have to be always cautious with low titers. If it's, 1/100 or 1/1000, then it's a true positive. Whereas if it's like 1/20 or 1/40, we have to kind of take a step back and see the clinical presentation. In your patient, it seems like it was a complicated course. There's the bithalamic involvement, there's the recurrent fever, the pleocytosis, and there was the skin lesions on the hands. So I was thinking of, other things that may present similarly. Things that came up would be like an interferonopathy, or as you mentioned, the primary immunodeficiency, or Aicardi-Gouttiere phenotype. Other thing, especially with that kidney involvement, I think there was a mention of some nephritis at some point.
She was on catheterization when she was having encephalopathy. So she developed cystitis and had some bulky kidneys on the ultrasound. So that settled down with antibiotics.
Okay, so that was out of the... Yeah, and then the other thing is, could this be an underlying mitochondrial metabolic disorder that can cause such presentation? Because her MRI is...
Yeah, we have even done a complete metabolic workup on her. So it was all negative. Her ammonias and lactase were normal, and she's remaining in remission now as of now. But the other complication which she has developed is with rituximab. She has developed persistent hypergammaglobulinemia, so on which she is on replacement therapies. She also had CT during her course of illness. There were nothing to suggest calcification, and she's a premorbidly normal child, so she was not fitting in with Aicardi-Gouttiere. And with the immunotherapy, she has recovered a significant, she has shown a significant improvement. As of now, she doesn't have any motor deficits and cognitively also doing well.
Okay, so these are more reassuring features then. Is she on long-term immunotherapies at this point?
No, she's only on a replacement dose of immunoglobulin, IVIG, because she has that hypogammaglobulinemia, which is now recovering.
And how long was she on the rituximab for ultimately?
So she was during the acute phase, she was given 4 doses, weekly doses, 375 milligram per meter square for 4 weeks. After 6 months, we did the CD19 B cell enumeration, and then also we looked at the immunoglobulin profile. There was some B cell repopulation, and also her immunoglobulin profile was normal. So we gave another 2 doses, 375 milligram per meter square, because her initial presentation was severe. So fearing a relapse, we gave her 1 more course of 2 doses. Subsequently, she recovered well, and radiologically also she was remaining stable. So we didn't give further courses of any immunomodulation, but she was having this persistent hypogammaglobulinemia later during follow-ups, for which she was started on the IVIG. And this immunoglobulin was done later because she had recurrent urinary tract infection. So she was having 3 or 4 events in a year. So that is the reason why we again went on, did the immunoglobulin profile, though her initial immunoglobulin profile was normal.
Can I ask, you mentioned she was irritable, and you mentioned encephalopathy and some tremulousness. I mean, the character of the tremulousness, was that tremors, or like, could it possibly have been myoclonus? I mean, maybe early presentation, I just start wondering about autoimmune encephalitis and whether perhaps any panel was run on that.
Yeah, we have done a CSF and serum PAT sample of autoimmune encephalitis panel. It was negative. She was ataxic, and she had some clumsiness, and she had dysmetria and dysheterocokinesia. So it was predominantly cerebellar. It was not like a myoclonus.
Thank you.
I think Dr. Amar's point is good to keep in mind. That the MOG antibody can be positive sometimes in other settings. I think we have a little bit of difficulty because your test is clearly different than ours, with knowing exactly how to approach that as a definitive positive or as potentially a low positive, like we could possibly see an MS or a leukodystrophy. I think certainly the clinical course has been reassuring. I'm not 100% sure if that's because this is definitive MOGAD, or if it's because there's some other neuroimmune process that was ongoing. The other thing that's a little unusual is that we do tend to have better success in general treating MOGAD with IVIG than with rituximab, although rituximab can work in about 70% of the time. So it may just be that that's kind of the overlap. But I'm glad she's doing well.
I think we'll end the discussions over here. We had a marathon session, so to say.
Thanks, Vishal.
Thanks for final comments.
Thank you, Vishal, and I thanks Dr. Sara and Dr. Amar for excellent presentations, and thank you, Derek, Jitangi, and Dr. Maya and Dr. Urani for wonderful discussions and wonderful presentations from Boni and Krutikya, mentored by Jasudra and Sangeeta. As I understand, we are already 36 minutes beyond our scheduled time, and still we are left with 91 people. So as a customary, we give a take-home messages to the people staying on. So I think take-home messages. Dr. Sara, take-home message from you, then Dr. Amar, then Dr. Derek, Jitangi, Maya, Dr. Urani. Please, everybody, some take-home message for the viewers. And anyway, this will be recorded, this part discussion, so it will be there. Yeah. Please, Dr. Sara.
So I think take home messages from my standpoint would be early and aggressive treatment of acute attacks, specifically for NMO spectrum disorder. The importance of reviewing the clinical criteria for MOGAD and knowing definitive diagnosis versus what may be a low false positive kind of a test, and also the fact that an initial MOGAD event wouldn't be treated with immunosuppression, but that we would require a second event, and that persistently positive antibodies are still a little bit difficult to interpret in the MOGAD setting.
Thank you, Dr. Amar.
My take-home point is we know that the neuroimmune conditions can affect the same parts of the nervous system, the brain, the optic nerves, and the spinal cord, but it's very important to keep the clinical acumen high, because it's more about how they present, the course, the recovery, how it looks on the MRI, and the response to immunotherapies that can actually guide us for one condition more than the other. And it's very important to take a step back and look at the as you guys all did, looking at things that support each condition and things that go against each condition, and then question the flags, and then broaden differentials accordingly.
Thank you. Derek?
No, I think I would just second Dr. Amar to basically say keep a very wide lens in the differential diagnosis and not to narrow down or overweight on antibodies, just as Dr. Sarah said. And just quickly to say to Dr. Sarah and Dr. Amar, please pass my regards to Brenda, because I worked with her briefly in Toronto and she came and visited us once.
Happy to do that.
Yeah, she's so busy with the budget times, right?
Even during non-budget time, she's pretty busy.
Okay, yeah, I know she's busy all the time.
And clinic.
Definitely. Jitangi?
I think I would like to, this is something very important for our region as well, because we are resource limited, and, some of the treatments that we discussed are very expensive. I would like to leave the message that rituximab is, useful across the three main disease spectrum that we discussed. So early use and adequate use, and, probably there's a lot of scope to explore the role of rituximab in the future. That's what I gathered from this discussion, and I think we'll look forward to its role in treatment of these conditions in the future.
Yeah, thank you, Jitangi. We're using Ritux quite a bit. It is really good. We also like it. Dr. Maya? Dr. Maya? Dr. Maya, you there? Dr. Maya? Dr. Urani?
And nothing to add from my side.
Okay, thank you. Thank you. Mahesh, something from your side?
No, ma'am. It was a very good discussion, ma'am, covering the common disorders. Thank you.
Vishal, want to say something? Any message from your side?
Nothing more, ma'am. I think it
Okay,
has been covered perfectly fine. Thank you very much.
Thank you. I thank everybody for having joined, and all the attendees as well. And we finish this current session of the neuroimmunology series. We come back after 9 months for the next neuroimmunology month, and we have fetal neurology and neonatal neurology from next month, and we're coming with the very debatable topic of hypothermia in HIE, the first Wednesday of March. Welcome you for all. And Mahesh, you want to sign off, please? Mahesh.
Yes, ma'am. I'll be giving the details in the putting in the details in the Yes and the WhatsApp group, and in the next Wednesday's webinar.
Thank you. Thank you so much.
Thank you.
Thank you for having
Thank you.
me.
Bye.
Pleasure. Bye.
Thank you so much.
Bye-bye.
Bye. Bye. Bye.